Today I'll talk about the challenge of antimicrobial resistance in human health. This will be from the perspective of a clinical microbiologist, whose role really is to aid the treating physician in identifying the causative agent of an infection and to provide information about the activity of antimicrobial agents that might be used against those organisms. I think everyone here is certainly aware of the story of Alexander Fleming discovering penicillin. We are very fortunate that he was observant enough to recognize that when he had looked at the plate that there was a reason the staph colonies were not growing around the mold, and that might be that it was producing a substance. We're also fortunate as well that there's a very European convention, which is in the summertime. They like to take many weeks of vacation and head off to the beach. We're also very fortunate that he and his laboratory associates did that as well and left their petri dishes out so that this event, which requires some time for the mold to grow, could take effect. Now, from that initial discovery until identifying the agent responsible, as well as to make it into a large enough quantity that it could be used sort of mass-produced, took about another 10 years. And I think, as is the case for a number of discoveries, there were some war efforts that actually helped speed that along. And this particular poster, I think, shows the clear recognition of the great value that penicillin would have in saving the lives, in this case, of many soldiers, but certainly as well as of many non-military as well. Unfortunately, however, what we've seen with the discovery and development of antibiotics is that as we discover and develop and use these, unfortunately, we often see the selection of resistant organisms and thus resistance occurring. If you look at this slide, I think what you can notice is from kind of the mid-30s to about 1960, there was really a golden age of discovery. A number of new antibiotic agents found, sulfonamides, penicillin, aminoglycosides, chloramphenicol, a lot of classes. However, as we move into the 70s and 80s, our approaches really became more one of incremental changes off of a nucleus, in this case a cephalosporin antibiotic. And there were many iterations, first, second, third, and fourth generation, all made in response to resistances that were evolving as we used the antibiotics. The last few decades, there have only been a few new classes that have been introduced, and really the last class that was introduced would be the oxazolone class around the year 2000-2001, and the drug is linezolid. That is really the one approved member of the class. So really, since the mid-70s, there's been this recognition that resistance development has been moving along rapidly. We're identifying and seeing many new resistance mechanisms. Also, from that time, we've seen a reduced interest in anti-infective development by pharmaceutical companies, especially so beginning in the mid-90s. Additionally, we have diminished infection control and public health infrastructure. Costs are important. We're all struggling with where to save money and how to best use our money, and so there are things that will suffer. Additionally, because of resistance development, we are seeing more and more limited treatment options for these agents. So in 1995, the American Society for Microbiology Task Force on Antibiotic Resistance made some recommendations as to how we could address resistance and make the best use of agents that we had. And their approaches were surveillance, education, and research. And I think this all makes very much good sense to all of us. Now, moving forward just a few years, in 2004, the Infectious Disease Society of America put out a white paper and began a campaign called Bad Bugs, No Drugs. What they pointed out is there was declining research investment in antimicrobial development, and the task force that they had identified problematic pathogens. They called these the escape pathogens because they escape therapy. They have an acronym with a K in the middle, and this lists the organisms that are talked about, including the hard-to-pronounce Acinetobacter. So in 2009, 5 years later, IDSA published an update on their Bad Bugs, No Drugs campaign. And their point really is here we are 5 years later, things are getting worse. In 2010, in a statement before the House Committee on Energy and Commerce Subcommittee, they said 6 years later, the drug pipeline and resistant problems have only grown worse. So clearly their efforts had not done enough at that point. And this is a slide that shows antibiotic agents that had received FDA approval, and I think it clearly shows the significant drop in numbers. So in the from 1980 to 1984, you can see 17. 2005 to 2007, it was down to 2. And from 2008 until now, there have been 3 new agents approved. One of those is really a topical agent and not for systemic or broad use therapy. So things are still going very slowly on this end. So considering they're hoping to get new agents, the Infectious Disease Society of America launched a 10 by 20 initiative, which was simply their call to have 10 new agents by 2020. This is certainly an auspicious goal, and we'll see what happens. Unfortunately, it looks like it's going to be a very difficult goal to reach. So certainly professional societies, government, there are any number of government task force and white papers that came out have had great concerns about antibiotic resistance. Sort of what about the public? Well, here, as one could see from a web page, if you will, from the New York Times, is a health writer writing about a deadly germ unleashed by antibiotics. This is about Clostridium difficile, so that when a person takes antibiotics, it disrupts their gut flora. This is an organism that can sort of spread out and take hold and cause serious morbidity and even death. I also point out that along with this article, there are sort of links to go to a series of any other articles that had been written by this health writer. And you see such interesting titles as Resistant Bacteria Meet Reality Television, Resistant Bacteria, Football Players, and Gay Men. So certainly headline catching. The one about football, many of you may remember in the early 2000s that St. Louis Rams football players had MRSA infections, and that was made some big news. Here's just another example, and I think there are many that one can find, of moms across America uniting to preserve antibiotic effectiveness of antibiotics, showing that 3 out of 4 moms are concerned about the use. Clearly, the public is well aware of this issue. Unfortunately, it is a very complex issue and a difficult one to address. So this particular slide sort of takes a lighthearted look of sort of where we've been in terms of the history of medicine. A couple thousand years ago, a medicine man would say, here, eat this root. We became more sophisticated along the way, came up with penicillin, some other new agents, and in 2011, unfortunately, at least in some cases, we're at this point where it's, here, eat this root again. We hope to change that. As surveillance is really a key part of the approach to address resistance, I can tell you on the human side, and this is not an exhaustive list, there have been a number of global programs that have been available. The Alexander, Mystic, and Protect programs were all really primarily supported by pharmaceutical companies in support of a branded agent that they had. Patent life went off, those programs have stopped. The SENTRY program, which began in 1997, primarily with a pharmaceutical company support, still continues, and at JMI Laboratories we keep that going with funding and support from a variety of pharmaceutical companies. There are national regional programs of surveillance as well. TSN, Europe has one called EARS. There's one in Canada as well. So there are surveillance programs going, actively looking to monitor and track resistance in human bacteria. On the veterinary side, there's a global program, the Global Salmonella Surveillance, collaboration between World Health and CDC. And there are also a number of national programs in Japan and in the U.S., and I think there are people in the audience here who certainly know much more about these programs than I do. So what I'll do today is go over some data on the organisms we're concerned about and sort of where we're at and the trends that we say in terms of resistant. And I'm going to do that based off the SENTRY surveillance platform. This platform consists of about 100 and 140 total sites. They're in North America, Latin America, Europe, and the Asia Pacific. The isolates that we get are deemed as clinically relevant, and we conduct it by asking for these in terms of objectives. We ask the sites to provide us their next 100 bloodstream isolates, or those from community-acquired pneumonia, and so on. All those isolates come back to north of Liberty, Iowa. They somehow find their way there. We re-identify those, as well as we do testing of all those isolates, because we want to make sure we've got testing in the same system at the same time to have the best chance at comparing this data over time. We routinely test something on the order of 35 to 50 antimicrobials each year, pretty much the most common antimicrobials that are in use on the human side. And we will test investigational agents selectively as we can do so. So if we look at what we will find from the SENTRY platform, these are isolates from bloodstream infections, very serious infections. And this is data that are listed from top to bottom and from left to right in terms of prevalence. So E. coli at about 23% is the most common pathogen that we are seeing as clinical microbiologists. What you'll also notice in the darker blue color that I've highlighted, Staph aureus and so on, those pathogens are those that were deemed as the escape pathogens by IDSA. So it's not surprising that, number one, these are fairly common, and the other problem, of course, being that they tend to be very, very drug resistant. I will point out to you that Salmonella is on the list, but you can see it's over in the second column down toward the bottom at less than 1/10%. I'm sorry, less than 1%. And I know that these data were looked at from 1997 to 2006, and at that time, Salmonella averaged in the bloodstream at about 0.3%. Certainly on our list, but not terribly common. And in terms of antimicrobial susceptibility, resistance was really fairly uncommon, less than 1% or so for the fluoroquinolones, and again, very low, less than a few percent for third-generation cephalosporins, which are important agents in human use, such as ceftriaxone, ceftazidime, and even cefepime. Also, I will point out on the list, you may well have looked, although it's a long list, Campylobacter didn't make the list. That's not to say that we won't see it occasionally, but it just wasn't in the top list. Okay. So what I'll do now is go through. So these are pathogens that we see frequently and that we're really concerned about in the human health side. And so we'll go through the information. We call these gram-positive and gram-negative simply based on a gram stain that turns them either blue or red. It's just a convenient term that we use. So if we look at resistance to selected antimicrobials by way of a snapshot, what was the percentage of resistance in 1997-99, and how did it look 10 years later? What we can see as you look at the different regions is that, number one, sorry. Oh, okay, perfect. Okay, great. I think what you can see as you look at these is simply, first of all, I'd point out that as we look at these three key kind of gram-positive organisms that are major problems, you'll see that the rates of resistance will vary by region, and further, if you can sort of drill into this data, you will see as well that there will be resistance rates that will vary through the individual countries. Ultimately, all resistance is local. The more granular the data can be, of course, the better it can be. In terms of general points, what I would point out is that for MRSA, which for the U.S. really has had the highest rate, you'll see this change from 34 to 58%. So in fact, MRSA had become the predominant type of staph, which is a significant change. The other regions tended to be a bit more flat. For vancomycin-resistant enterococcus, as we heard mentioned earlier, something of concern, You know, the U.S. started during this time frame relatively high at 17%, has gone up to 30%. Most of that resistance is in the species of Vesium. And finally, for the number one respiratory pathogen in human health, Streptococcus pneumonia, one of our major problems is high-level penicillin resistance. And as you look at the regions, it certainly occurs, and it's a problem in all regions. But Asia-Pacific, you can see Asia-Pacific is one where the rates had climbed really quite high. Okay. Now, something of interest in looking at the MRSA rate in the U.S., you'll notice this climb, as was pointed out, it climbed up to around 58%. We saw in 2009 a drop. So this is an encouraging event. It's a significant drop. But whether it's a real trend at this point, we don't know, and we will. It's something that needs to be followed. And unfortunately, the problem with many of these organisms, such as MRSA, is not just that it's resistant to a particular group, and methicillin is really just the marker for all beta-lactams. So a Staph aureus resistant to methicillin is resistant to many, many antibiotics. In fact, the most used classes of agents that we use. That's bad enough, but on top of that, many of these staph are resistant to other classes of antibiotics. So as you look at this slide, what you can see is that for erythromycin in blue, we're still where more than 90% of these isolates are resistant to erythromycin. More than 70% are resistant to the fluoroquinolone levofloxacin. So these are multi-drug resistant strains, and that's what really exacerbates the problem. Now, for the good news, one of the newer agents, as I mentioned, that had been approved, although now about 10 years ago, linezolid, it's holding up very well in terms of its activity against the gram-positive organisms. And you can see from the slide in the bottom right-hand corner that only 0.3% of the overall isolates are resistant to this particular drug. So it's a very good agent. And there are a couple other agents that have come on board recently. Not only do we track resistance, as I'm describing it now, by an MIC or phenotype, we also do want to follow mechanisms whenever possible, because we're interested in trying to understand and or predict if this is something that is more likely to spread or not. Is it on a mobile genetic element, or is it a mutational event in that organism itself, in which case a clonal spread would be required to lead to resistance. In the case of linezolid, since there are only 5 in the U.S., we looked at all these, and you can see that 3 of these in blue were either ribosomal protein mutations or ribosomal RNA mutations, mutational events. The 2 highlighted in red, CFR, are an enzyme that methylates the ribosome and can lead to resistance. And this is a bit more of concern because it's a mobile element and has the potential for this horizontal transfer moving across. CFR was really first noted a few years ago, about 6 years ago. The good news is, although we do see it popping up more and more, it really hasn't taken off in a major way. Now looking at vancomycin-resistant enterococci, I think it's really pretty straightforward. It's pretty obvious looking at the orange bar, the lighter year, that no matter what region we're looking at, the rates have been climbing. And climbing dramatic. And as mentioned earlier, the U.S. started kind of high and has moved a bit higher. And I think an interesting piece of data can be seen on this slide. First of all, when we look at North America for vancomycin resistance in Ephesium, as mentioned, that's a species that has most of the vancomycin resistant. In 1999, it was pretty high at about 60%, and it's been climbing up a bit. In Europe at 1999, it was basically right around 0, and it's been climbing up a bit. The star denotes where avoparsin in Europe was basically at that time withdrawn. So what is interesting is that in the U.S., right, avoparsin was not used, and we've had a significant problem for a long period of time, whereas in Europe, their problems really only manifested themselves after its use. And so Again, I understand this is very complex, but I think it shows, at least in simple terms, one could see a bit of a disconnect in trying to understand this. These are data on Streptococcus pneumonia, and what's interesting about here is we actually can look at healthcare interventional acts on resistance. What was done in 2001 was the introduction of a vaccine. This vaccine was a heptavalent vaccine, so it was active against 7 serotypes of pneumococcus that tend to be resistant. So the idea is if we can reduce these, we can reduce resistance. So if you look at the slide, and each line is a different antibiotic, what you'll notice is after the introduction of the vaccine, it did work in the sense that resistance rates dropped a bit. Unfortunately, it's pretty clear that it didn't take a long time for resistance rates to these agents to come higher. Other clones, other serotypes that were resistant started to predominate. So once again, a new vaccine has been introduced in right around 2009, and this will act against 13 different serotypes. And so we'll have the opportunity to see what can happen. I think, unfortunately, since it is a matter of survival, I think we'll see the bacteria bounce back again. But hopefully this is enough serotypes to hold them back a little longer. And as mentioned for staph, it's not just one resistance that we have to worry about, and penicillin, again, represents a large class of antibiotics. It's also the fact that many of these strains are multi-drug resistant. So you can see, for example, from, again, over about a 10-year period, how the rates drop for erythromycin, for clindamycin, and so on. So multi-drug resistance is a common theme for these pathogens. Okay. Now for the talk, we'll change directions a bit and talk about some of the gram-negative organisms. On the gram-negative side, first of all, we'll cover the Enterobacteriaceae, E. coli, Klebsiella, and Enterobacter. For the gram-negatives, one of the major problems we face are enzymes that hydrolyze our newer generation cephalosporins. These enzymes are called ESBLs, extended spectrum beta-lactamase. They are a major, major problem. We also have concerns about quinolone resistance in the enterics, and also enzymes that chew up the carbapenems, which are really our most potent beta-lactam, and that we have been relying on the last 10 or 15 years. Carbapenemases are also becoming a problem. And again, as you look across the regions, you'll see there are differences. Latin America has significant problems with ESBLs, as does Asia Pacific. It is a problem that's growing in the U.S., and it depends on the organism. It's very organism specific. Klebsiella is a huge problem, much more so than E. coli. These are data that help, again, show why it is valuable to look at mechanisms. These organisms were assumed to be resistance by a mechanism called derepressed AMC. That was based on the MIC. That is, they have a high ceftazidime, which is a third-generation cephalosporin, have a high ceftazidime resistance, greater than 2. But as you look across these 3 regions, you don't see anything really remarkable that stands out. It's sort of bouncing around. Nothing appears to be changing in a major way when you look at the data this way. But when we actually look at the mechanisms, we see that there's really quite a bit going on. If you look at the APAC, the APAC region on the right-hand side of the slide, or your left-hand side, what you'll see is that the majority of the isolates in the beginning of this period were truly the derepressed AMC, the big red bar. Not quite 10 years later, you'll know that things have reversed. And what has happened is the blue bar represents these mobile elements, the ESBL enzymes, carbapenem enzymes. So although the overall rate hasn't changed, they're now predominantly a type that could be mobile, could transfer horizontally, and could be of great concern. The last 2 organisms I'll cover briefly are Pseudomonas and Acinetobacter. Again, these are significant problems because they're so very, very multi-drug resistant. For these agents, we may only have one or two choices, and sometimes no agent that, at least by susceptibility testing, says that it will work, in which case cocktails are used, and one hopes that the patient's immune system and other things are enough to save the day. For Pseudomonas aeruginosa, we know a lot about the mechanisms, especially for the beta-lactams. And fortunately, one of the mechanisms we're very concerned about is called a metallo-beta-lactamase. It leads to high-level resistance to sort of all known classes of the beta-lactams, and we're fortunate in that Pseudomonas aeruginosa, although it exists, and we now find it in various parts of the world, it tends to only be in the 1 to 2% range. That's the red IMP15 in this case, one type of many. So we're fortunate that remains low, and that's one that I think we're all greatly concerned if it could expand. Acinetobacter is an organism that really only became a problem in terms of prevalence less than 10 years ago. It is occurring in a variety of infections, skin infections, and pneumonia. In 2006 at ICAC, it was pointed out that carbapenem resistance in this organism rates were fairly high and appeared to be climbing. This rate at this time at an order of about 40%, and in fact now many of them, probably 40% or greater, are multi-drug resistant. In a slightly later study from the MYSTIC study, the data from this are simply here to point out that the spread of these of resistance for Acinetobacter really appeared to be primarily driven by clonal expansion, so that there were organisms clearly were very fit and able to spread. So at these institutions, when they had them, they spread. And unfortunately, we also, when we have a clone spread that's multi-drug resistant, we have an explosion of multi-drug resistance. So in summary, resistance to antimicrobials continues to evolve. Resistant mechanisms are diverse, and they're often multiple and even in individual organisms. The therapeutic choices available may vary. Fortunately for the gram-positives, we do have more choices. Again, several agents that seem to have fairly good activity. However, for multi-drug resistant gram-negative, we are really having some problems and concerns, and the drug pipeline in this area is especially thin, with really no good gram-negative agent anywhere close in development for human use. The pharmaceutical industry is generally disinterested in continuing discovery research to develop such agents. The recent excitement is really my hope more than fact or reality, I suspect, but one can always hope. And additionally, and something I've talked a lot about, is the regulatory approval times really have increased as more information is required. It becomes more difficult to do the studies. So to manage antimicrobial resistance, it really requires an approach from many fronts. Formulary controls to make sure antibiotics are used when they're needed in the right way, better infection control. Microbiology test systems and epidemiology really need to be working well, and there are some significant problems that are not the subject of this talk. One needs interested medical staff and institutional commitment of resources to make these things work. Global surveillance systems, but certainly more local surveillance systems are needed. Education is important for healthcare workers and certainly for the public. And although certainly not the be-all and end-all solution, increased drug development, I believe, is really a necessity. So in ending the talk, I show a slide from David Livermore, who is a British microbiologist, and this is really clearly written based on the UK perspective. A couple of points that he makes, I think one has been made earlier, but I would just point out in the last point, and to paraphrase what he was saying, and he was just saying in essence that, you know, banning zinc bacitracin was something that could be done, but there are other contributing factors that are undoubtedly more important. These are harder to tackle and to address. And so one will hope that as we understand what really contributes to the problem, that we can also focus and address on those things that may make the biggest differences. Also then just finish with an acknowledgement for those at the JMI Laboratories who help keep this system running, as well as provide much of the information, and some of the consultants who work with us around the world in Australia and elsewhere to help us. And with that, I'll close. Thank you.